All right. Good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound case series. Before we get started, I just want to put up another plug-in for the AMSSM Library of Sports Ultrasound Pathology. For those who are unaware, this is a resource for all of us who do sports ultrasound to review uncommon pathology. At this point, we're really encouraging people to submit high-quality images, especially trainees. This is a great way to get involved with the AMSSM ultrasound community. There is a review process for all the submitted cases. They're published on the AMSSM website. It's a really, really great resource for everyone. Any questions, you can ask Josh Romero. His email's listed here, and then there's a QR code that you can take directly to the page. All right. So today we're going to be talking about lateral parameniscal cyst with Dr. Stephen Zhao. Stephen attended college at the University of Pennsylvania, and he earned his medical degree at Seba University School of Medicine. He completed a PM&R residency at Georgetown University, and he's currently a fellow in sports medicine at Hospital for Special Surgery. His interests include diagnostic and interventional ultrasound, comprehensive sports coverage, and athlete spine care. All right, Stephen, you can go ahead and share your screen.
Okay.
That looks great.
Thank you. Thanks, Dr. Betcher and AMSSM for this incredible opportunity. I've definitely learned a lot from these online fellow lectures, as well as the various videos that AMSSM puts out. So I'm excited to be here today lecturing on lateral parameniscal cyst and the lateral knee scanning protocol. Just want to give a quick shout out and thank you to my fellowship director, Dr. Kirshner, for his countless hours of ultrasound teaching, as well as Dr. Beatty for helping me with this case and training as well. So I'll first talk about the history and physical about the patient, and then dive into the images we took, and finally review the ultrasound report and correlate that with the MRI. So our patient was a 41-year-old female, no prior knee issues. She developed left lateral knee pain with insidious onset, and she kind of got into her new year, new me attitude a little early on and started working out with a trainer, joined all these various exercise classes that we see, and started to develop gradually worsening pain that was exacerbated with box jumps and squats, particularly with landing. And she denied any associated swelling. On exam, she had knee flexion to 120 degrees with pain at end range, as well as tenderness along the lateral joint line. She also had a positive McMurray's that elicited left lateral knee pain, as well as a positive Thessaly, and then a negative Varus stress test. So this is more of a general differential diagnosis for someone with lateral knee pain coming into our office. The things that we want to consider are lateral ligament sprain, IT band syndrome, whether it's distal friction syndrome or bursitis, lateral meniscus tear or cyst, popliteus tendinopathy, and biceps femoris tendinopathy, probably a little lower down on the differential. So the X-ray we took of our patient demonstrated narrowing of the medial compartment, but no joint space narrowing or osteophytes seen in the lateral compartment. And the transducer that we selected was a linear array transducer. And these are pictures of myself and my co-fellow positioning ourselves. So the way we positioned the patient was side lying on her right side with the pillow between the knees. And this helps with some comfort as well as some slight knee flexion, and also allows her symptomatic knee to be in a slightly varus position, which I'll talk about later on, can optimize some of our images. Alternatively, we could have the patient in a supine with the leg internally rotated. So a very common technique for the lateral knee that I learned is the Z-scan protocol, in which we start at the IT band and anchor off Gertie's tubercle with a proximal end on the lateral femoral condyle. Then we rotate the distal end of the probe to the fibular head to capture the lateral collateral ligament. And then we rotate the proximal aspects to find the biceps femoris. And additional structures that we want to look at according to the AMSSM protocol and lateral knee protocol are the lateral recess of the knee, the meniscus, tibiofemoral joint space, the popliteus tendon and muscle, the lateral patellar retinaculum, the patellofemoral and tibiofibular joint, as well as the common fibular nerve. And some of these images were from the patient's contralateral knee just to demonstrate normal from then the abnormal pictures. So the first structure that I started with is the IT band. And something I learned to be very helpful is palpation, whether you're scanning, the knee joint or shoulder joint, really palpating the structures, whichever ones you can, is I find to be very helpful. So I started with palpating Gertie's tubercle to find the IT band. And also sometimes if you have just evaluated the anterior knee, you can just slide laterally from the patellar tendon and anchor off Gertie's tubercle that way. And then I rotate the proximal end of the probe to locate the IT band. And so with the IT band, we're evaluating for thickening as well as fluid, since it does cross the lateral joint line here. And this is also a good way to assess for any joint effusion. And here we don't see any. The proximal IT band is important to scan as it crosses the lateral knee joint to the lateral femoral condyle, since you want to, again, evaluate for any thickening or fluid that would be indicative of IT band distal friction syndrome. The bottom image is the IT band in short axis, which you want to evaluate for any focal thickening or hypoechogenicity, which typically happens towards the posterior aspect. And here the IT band bursa will also lie just below the IT band. And it's important to use light transducer pressure here to prevent displacing any fluid. So seeing this in a patient with lateral knee pain and tenderness or sonal palpation here could suggest IT band distal friction syndrome. I've seen a couple already in fellowship in patients with total knee replacements. Again, you might see fluid coming from the lateral recess here of the knee joint, so don't mistake that for IT band bursopathy. And additionally, you can also perform dynamic testing if the patient reports snapping at the knee. So next to the lateral collateral ligament, we can rotate the distal aspects of the probe posteriorly to the fibular head. And here we can see the hyperechoic and fibular architecture of the LCL, which extends from the lateral femoral condyle to the lateral aspect of the fibular head. It's important to know that the distal insertion on the fibular head may appear thickened due to the distal biceps femoris tendon bifurcating superficial and deep to the LCL. We can also see the tibia below and part of the tibiofibular joint, which we don't see any fluid. And one of the challenges that we encounter with the lateral collateral ligament is the slight valgus angulation of our knee joints causes a slightly wavy appearance and possible anisotropy, which is where the pillow between the legs can help place the patient in a varus position. Here we can also perform a varus stress test to look for disruption and increased laxity of the ligament. Here we can see the proximal portion of the lateral collateral ligament originating off the lateral femoral condyle, and the popliteus just deep to it. So for me, I think the popliteus is a nice kind of landmark to help identify the LCL and vice versa. From the LCL's attachment onto the fibular head, the proximal aspect of the transducer is then rotated posteriorly to the coronal plane. And we can see that the muscle is hypoechoic proximally, which helps you clue us in that we're in fact looking at the biceps femoris muscle. Again, the distal biceps femoris tendon can appear heterogeneous since the fibers do bifurcate superficially and deep to the LCL at the fibular head. So this should not be mistaken for tendinopathy. So returning to the popliteal groove in the lateral femoral condyle to evaluate the popliteus tendon as it curves posteriorly around the joint. The popliteus is best evaluated from a posterior approach, where the muscle belly is located between the tibia and the tibial vessels. So it's important not to mistake the anisotropy here for a tear because of the curvature of the popliteus. The top image is the popliteus tendon short axis, and the bottom image is capturing the popliteus in long axis. So here we can also see the rotation of the transducer required to capture the popliteus in long axis. And then looking at the joints, we want to evaluate the tibiofibular joint proximally for effusion and osteophytes, which we do not see here. Below is a picture from Dr. J. Smith's article on identifying the proximal tibiofibular joint. And superficial to the tibiofibular joint is the anterior superior proximal tibiofibular ligament. And then the lateral patellofemoral joint here, we're looking for osteophytes as well as joint diffusion, and here we don't see any. And the main nerve to scan in the lateral knee is the common fibular nerve, looking for loss of intravesicular architecture, swelling, or entrapment, which we do not see here. And then the fibular nerve will then travel around the fibular head into the fibular tunnel as it dives between the two heads of the fibularis longus. Just pause this and okay. So coming back to our structure of interest, we can locate the anterior horn of the lateral meniscus, which is a fibrocartilage and hyperechoic structure, like a triangle between the femur and tibia. So here we look for meniscal extrusion, parameniscal cysts, or tears. And this was taken from the contralateral knee. And then to look at the posterior horn, I found that you really need to angle your transducer like inward or anteriorly. And here we can see a picture of that. Again, looking for any clefts, tears, cysts. And when we did look at the patient's lateral meniscus, we had to switch machines, but here we do see a multiloculated, mostly anechoic, but also hypoechoic fluid abutting and extending into the body of the lateral meniscus. Sometimes you can see increased through transmission if there is anechoic fluid, which we kind of see on the left side of the top image. And there is a hypoechoic cleft as well, suggesting a horizontal meniscal tear. Here, she also did have tenderness to sonal palpation over the area. And in the bottom image, we see the hypoechoic cleft through the posterior horn as well. So to ensure that this was not fluid coming from the suprapatellar recess or joint space, we did scan the suprapatellar recess just to rule that out. Also, we didn't see any fluid from the lateral recess earlier. So this further suggests that the fluid that we are seeing is from a parameniscal cyst. One of the things I found was that small meniscal cysts may be actually located within the meniscus, but larger parameniscal cysts can be quite extensive, as we see here, and are typically associated with meniscal tear. And it has been reported that ultrasound has over a sensitivity and specificity of over 90% in diagnosing parameniscal cysts. So with our summarizing our findings here with the ultrasound report, we found no abnormalities with respect to the iliotibial band. The lateral collateral ligament was intact, no evidence of tear. The biceps femoris muscle and tendon were normal. The popliteus tendon, common fibular nerve, and joint spaces were normal as well. And the lateral meniscus revealed a multiloculated heterogeneous cyst abutting and extending into the body of the lateral meniscus. A hypoechoic horizontal meniscal tear was seen communicating with the parameniscal cyst. So our findings were suggestive of a complex and multiloculated lateral parameniscal cyst with a horizontal meniscus tear. And we were able to further confirm this on MRI where I was able to meet with our radiologist to review it. And we can see a large cyst extending through the anterior horn and body segment and the posterior horn of the lateral meniscus. The cartilage in the lateral compartment was noted to be preserved. So on the left, we have an axial outlining the cyst along the periphery. The middle picture demonstrates the cyst along the anterior aspect, and on the right, we have a coronal proton density demonstrating the cyst in the horizontal cleft. And then just a bonus picture, we did bring her back for an aspiration of parameniscal cyst for diagnostic/therapeutic aspiration, which did provide significant relief for symptoms. Thank you very much. I'm happy to answer any questions or discuss anything further.
Thanks, Stephen. That was a great, presentation. I really appreciate, um, when folks go through a protocol and have it be an intentional protocol, right? Not just kind of jumping around and, scanning a couple of things here and there. Your, protocol-based evaluation of lateral knee should give you a chance to confirm your diagnosis, rule out your differential diagnosis, and then assess for other things which may be a little bit unusual. And so, for me, my lateral knee scan and protocol, I tend to actually move the patient around a little bit. So I typically start with them, and there's not a right answer to this. I typically start with the patient in the supine position and start with kind of the anterolateral structures. So I'll get a suprapatellar recess just to take a look at what sort of effusion status are we looking at. That also puts the lateral patellofemoral recess kind of in a gravity dependent position. And so if there is fluid extending into that lateral recess, that's when you'll find that typically. When people are in that sideline position, unless they have a large effusion, it tends to kind of follow the path of least resistance and head medial and in superficial or superior. The other thing I find is that the image you showed of the IT band, if you want to, could you maybe
Yeah.
go back to that image?
Sure, yes.
One thing that definitely needs to be noted and can really confuse people on the lateral IT band is on that bottom image, you have the patellofemoral recess on the right side of the screen, and you can actually see some of the cartilage coming off. And so that lateral joint recess actually extends underneath the anterior edge of the iliotibial band at the level of the lateral femoral epicondyle. And so if you have fluid deep to the IT band, that does not always equal IT band bursitis, as you may call it. And when people are in that supine position, any fluid that extends underneath the IT band that goes away then if you put them in the sideline position is likely going to be related to that. And so what you'll see is kind of right where you have that ITB labeled in the center of the screen. That's maybe a little bit behind where kind of the anterior end of the ITB bursa is. Beyond that, more anterior, if you see fluid, I would be highly suspicious of a joint pathology versus IT band pathology. And so I think that just bears mentioning because that's something that we frequently see trainees tripped up on when they're scanning and presenting to us is they'll call fluid under the IT band, but it's really a joint diffusion. And so just remembering that looking more posterior, central to posterior IT band is that IT bursa. And also, with the IT band, there's multiple areas of pathology, right? Some of them are at that lateral femoral epicondyle, and some of them are actually kind of insertional tendinopathy at Gerdes, which we see, more commonly in arthroplasty folks, which doesn't really apply to this patient. So I'll start with people in that supine position and look at those structures in the lateral retinaculum and how that attaches to the lateral structures. Then I'll flip them sideline like you do. I think the pillow in between the knees is a great idea. If you're having a really hard time scanning the lateral collateral ligament because you can't get it under tension, the other thing you can do is if people are in that supine position, you can put them in a frog-leg position. and it becomes a little bit awkward to get your transducer on there because you're kind of holding like up obliquely against gravity. But that LCL is really easy to palpate. It's tight like a guitar string in that figure four position. And so it's really easy for you to clinically find that and then put your transducer on there to understand what that structure is doing under tension. And so that's just another LCL trick because that structure can be really difficult to visualize. It's oftentimes longer than the footprint of our transducer, so you can't get both the femoral and fibular origins in the same image. So like you did, there's oftentimes a distal picture and a proximal picture. As machines are better and you get more experience, you can do like a panoramic view on that structure and get that whole distance. But then, as you pointed out, that distal LCL is oftentimes another point of kind of hang up for individuals who are just starting to scan. And I always like to think, I think one of your other images had it maybe a little bit better, but it looks to me like a hamburger. So the LCL is like kind of the burger patty, and then the biceps femoris oftentimes, yeah, like you have there is wrapped around like a bun on top and a bun on bottom. So you should see that picture there, and you can see the same thing if you go long on the biceps femoris. You'll just get a different orientation of the fibers. You'll have the biceps femoris fibers in a longitudinal view, and then the LCL ones will be a little bit more oblique, like you see your biceps femoris ones here. And then, you covered the lateral structures pretty well. The popliteus is definitely a challenging structure. When you see the articular cartilage and the tendon diving over, that's a really good sense that you're on that structure, not something else. It is not uncommon for people to get long views of the popliteus or the lateral collateral ligament or something else and think that they're on one structure, but they're really on another one. So looking at those different landmarks to know like what structure you're actually on, because there's several that run very, very similar orientation. Um, and then I'll finish off my scan actually, Stephen, by putting people prone. And I think getting them prone is actually a really great way to look at that posterior hornolateral meniscus. And and the other thing that you can see with that are, sometimes people have ganglion cysts associated with the lateral gastroc. And so as we're talking about, cystic structures about the knee, looking at that lateral gastroc, especially like at and above the femoral condyle level is really important. And recognizing what is lateral gastroc versus other structures can be quite challenging. And so just scanning a little bit medial on that image that you have right there, just scan a little bit like posterior medial, which sounds like an odd direction to say when we're looking at the lateral knee, pulls up that lateral gastroc tendon. And certainly you can have symptoms related to lateral gastroc tendon and in ganglion cysts associated with that, fabella, etc. And so I think those are kind of the major structures on the outside of the knee. And then when we talk about, the parameniscal cyst, which you covered really well, I think, it's really important to get orthogonal imaging on that. And so I could have missed it, but I saw kind of a long view along the meniscus with it, but not a transverse view of that. So we want to get measurements of those structures. I think it is very important to look at hypervascularity within these structures. Not all cystic structures are cysts. And so looking and using our, power Doppler imaging or, SMI or whatever you have on the system that you have is appropriate. And so just making sure that there isn't anything abnormal associated with these. And just from like a what do you expect standpoint, most of these are medial, but we definitely see them lateral. And I guess my experience has been they're usually a little bit more symptomatic lateral. People coming in for them tend to be more bothered laterally. I'm not exactly sure why that is. They're almost always associated with a horizontal cleavage tear. And for almost everyone, you should be able to see that cystic structure extend to a cleavage tear. So if you see what you saw and you see that extending to the cleavage tear, which is what you saw on the meniscus, that was a great pickup as well. Those are almost always parameniscal cysts, and unless proven otherwise. And then we definitely see those abutting the meniscus. We don't, if you see a cyst on the lateral knee and you don't see anything abutting the meniscus, you should definitely have a high index of suspicion that this might not be a parameniscal cyst. And then you have to go down your cystic slash soft tissue mass differential diagnosis and scanning and things like that. But yeah, so I know there was a lot of things there, but overall, I think you did a great job with this presentation. I'll open it up if anyone else has any comments or thoughts that they want to talk about. All right, sounds good. Well, it sounds like we can end today there. Stephen, thank you so much. That was great. Just as a reminder for everyone, we'll be back on February 16th. We'll be talking about FDP tendon tears with a couple of fellows from Detroit Medical Center. So we will see you all then. Have a great weekend. Thanks.
Thank you very much, Dr. Betcher.